Before getting into the details surrounding how to repair fractured bones, we require a sound understanding of the normal anatomy and blood supply of these bones. Without a good blood supply, a fractured bone will not heal in the desired time, and so we need a working knowledge of this blood supply and how to protect it if we are to succeed. We also need to know how the fractured bone will heal and over what timescale. Here we'll discuss normal bone healing so that later we can fully understand how this can be affected by different forms of fracture repair. Long bone anatomy. The long bone is composed of three principal parts: the diaphysis, the epiphysis, and the metaphysis. In the young growing dog, the epiphysis and metaphysis are separated by the physis or growth plate. There is a major growth plate, the top and the bottom of each long bone, although some parts of the long bones develop from separate centres of ossification and have separate small growth plates. Examples include the greater trochanter of the femur and the tibial tuberosity. Growth plates close as the dog matures, and the time at which this happens is dependent on the specific growth plate as well as the breed. In general, growth plates of the larger breeds close later than those of the smaller breeds. Growth plate or physial fractures are not uncommon in young growing dogs and can result in debilitating lameness. Due to the rapid healing potential of these youngsters and the fact that most growth plates are associated with joints or the attachments of major ligaments, failure to diagnose and repair these within a short period of time may leave the dog with a chronic, severe deformity. We'll talk about how to repair some of the more common growth plate fractures or separations later. At the end of each long bone, the epiphysis has a covering of articular cartilage to form the joint surface. Long bone blood supply. Long bones receive arterial blood supply from three principal sources. The first is the major nutrient artery, which enters the medullary cavity of the bone through a nutrient foramen, normally midway along the bone and often visible in X-ray, particularly in younger patients. This nutrient artery gives rise to the ascending and descending medullary arteries, which in turn supply the inner two-thirds of the cortex. The second principal blood supply comes from the metaphyseal arteries at the top and bottom of each bone. They supply the metaphyseal and epiphyseal regions of the bone. In young dogs, there are separate epiphyseal and metaphyseal blood supplies separated by a growth plate, which unite at maturity when the growth plate closes. This explains why in young dogs, when we get growth plate fractures, the separated piece of bone retains its blood supply. The one exception to this is the head of the femur, which I'll explain in the next slide. The third principal blood supply to the bone is the periosteal arterioles, where muscles attach to the bone. These provide a minor contribution, but will nourish the outer third of the cortex. When we're repairing long bone fractures, the temptation is to strip away as much of the soft tissue as possible to be able to visualize the bone better, but in actual fact this is going to have a detrimental effect on the healing of this bone, since we will be destroying some of its blood supply. We need to preserve as many soft tissue attachments as we can. The venous system operates centrifugally, with flow from the medulla to the periosteum, and there is no true capillary network as with soft tissue. Tiny vessels run through channels in the bone, allowing the passage of nutrients to the osteophytes. As we've just mentioned, because the epiphysis in the puppy has its own blood supply through the epiphyseal artery, when we get growth plate fractures, the separated piece of bone retains its blood supply. The one exception to this is the head of the femur. Here, the articular cartilage, shown here in yellow, is continuous with the growth plate. So the epiphyseal artery here must penetrate through the growth plate to supply the epiphyseal bone. If the femoral head gets detached from the proximal femur through the growth plate in a young dog, it will lose its blood supply and may undergo avascular necrosis. This is of importance because it's a fracture type that is not uncommon, and one where a femoral head excision surgery, which we'll discuss later, is preferable to limb amputation and is a reasonably straightforward procedure. Long bone healing. Fundamentally speaking, the fracture results in an immediate hematoma, which then gradually becomes granulation tissue. This is replaced by fibrous tissue, which is gradually replaced by cartilage. and then eventually the cartilage undergoes ossification to become bone. Each of these tissues is mechanically more resistant to strain than the previous one. And strain is basically the amount of deformation the fracture site or gap experiences during weight bearing. And the bone eventually remodels over many months and years. The long route from fracture to formation of bone has the same start and end point, i.e. the fracture itself followed eventually by new bone, but the way in which that new bone is formed will differ. And the formation of new bone at the fracture gap is determined by the amount of movement at the fracture gap and the size of the fracture gap, which in turn are determined by our choice of implants used to stabilize the fracture. Simply put, the mechanical environment created by the implants dictates the type of bone healing that will occur. The two critical factors are the size of the fracture gap and the movement at the fracture gap. These will influence whether we get direct bone healing or, more commonly, indirect bone healing. Most of the fractures we'll be discussing today will heal by indirect bone healing because that is what happens with the types of implants we will be using, but I'll describe both types of healing just now. Bone healing can be broken down into primary or direct bone healing and secondary or indirect bone healing. And primary direct bone healing is further broken down into contact or gap healing. These are both achievable using plates and screws, and here we aim to get absolute stability. Here the bone will heal by the process of either cutting cones laying down new lamellar bone directly or intramembranous ossification via Haversian remodeling resulting in woven bone. There is no cartilage stage as seen in the previous slide. Interfragmentary strain must be less than 2% for this type of healing to occur. Secondary or indirect bone healing that occurs with the use of external coaptions, IM pins and external skeletal fixators, we're aiming to get relative stability. Here the bone heals by a combination of endochondral ossification, where the process includes the cartilage stage as shown in the last slide, and intramembranous ossification. In this case, interfragmentary strain only needs to be within 2 and 10% for the endochondral ossification process to occur. Now these are definitions, and bone healing will occur as a combination of these two processes depending on stability throughout the fracture repair. Primary bone healing relies on complete fracture reduction with absolute stability, and we can normally only achieve this using compression implants like dynamic compression plates, so we'll not be discussing this in any depth today other than a brief description of how it works. Secondary bone healing is what we are aiming for with the fractures and fixation types that we're going to discuss later, and this is predominantly represented by the process illustrated in the previous slide with the slow transition from fracture hematoma to bone. Primary bone healing involves new bone being laid down directly across the gap with no intermediate granulation, fibrous or cartilage stages. There is no formation of a callus. It can only happen when there is a gap of less than a millimetre and less than 2% of mechanical strain between the fragments. Mechanical strain is basically the amount of deformation the fracture gap or site experiences during weight bearing. And this mechanical or gap strain is the change in length of the fracture gap during loading divided by the original fracture gap length. That is, the bigger this change in length during loading, the higher the strain. An unstable fracture site experiences a large degree of strain, whereas a rigidly stable site has very little. Primary or direct contact healing refers to a situation where the fracture gap is less than 0.01 millimeters and there is no mechanical strain at all between the fragments. This is only achievable using dynamic compression plates or lag screws with neutralization plates. These bone ends have been compressed together so there is absolutely no gap. The healing method here is cutting cones of osteoclasts are followed by osteoblasts, and bone is laid down in line with the long axis of the bone. Now, primary or direct gap healing, on the other hand, refers to a situation where the gap is between 0.01 and 1 millimeters and the mechanical strain present is 2% or less. And this is usually achieved by using a rigid neutralization plate. And there is a small fracture gap because the bone ends are not compressed together. And the method of healing here is new bone is deposited across the gap by intramembranous ossification perpendicular to the bone's long axis, eventually being remodeled over many months in a longitudinal plane. I'm not going to go into the microscopic detail of the mechanisms of bony healing with primary or direct bone healing, since this is not our topic of discussion today. Secondary bone healing will happen where we have a fracture gap of more than 1 mm and a mechanical strain of over 2%, i.e. a less stable fracture repair or a fracture repair with relative stability. In this situation, a completely different path is followed, seeing the transformation mentioned previously of hematoma to granulation tissue to fibrous tissue to cartilage and finally to bone. This process is endochondral ossification. Each tissue is stiffer than the previous type, reducing the mechanical strain at the fracture gap and so allowing the next tissue stage to develop. Basically, the biology of the situation changes over time to produce a fracture site with increasingly less strain and so making it more amenable to the formation of bone eventually. It has to be said though that unless the mechanical strain falls to between 2 and 10%, then bone will not form by this process. This type of bone healing is typified by the presence of a callus, and is typical with the use of IM pins and external fixation devices or certain types of plates, where there is no compression over the fracture gap and the bone ends are not in very close approximation. Secondary healing is actually a combination of predominantly endochondral ossification, but also intramembranous ossification too. This is an image of an X-ray of a distal radial and ulnar fracture in a dog where there is primary or direct gap healing. A neutralization plate and screws has been applied. You can see the fracture gap here, which will be less than 1 mm, and here we have the healed fracture with no evidence of callus whatsoever. This is an image of secondary or indirect healing in a mid-shaft femoral fracture in a cat that was repaired with an IM pin and 2 cerclage wires. And you can see here there is clearly evident bony callus. Counterintuitively, secondary or indirect bony healing occurs rapidly in comparison to primary or direct bony healing. If you take 2 identical fractured tibias and repaired one with an external fixator and an IM pin, and the other with a compression plate, and you removed all of the implants after 8 weeks, the external fixator IM pin tibia would likely have a good callus and be able to bear weight, whereas the direct compression plate tibia would possibly refracture. There are situations where secondary indirect bone healing is not ideal, for example where joint surfaces are involved. We do not want a callus here. However, there are many instances where the more biological approach of doing less damage at the fracture site using an external fixator and IM pin combination is a good trade-off for the animal developing a callus. Applying an accurately contoured dynamic compression plate means stripping back more soft tissues from the bone surface than using an ESF or IM pins, and as we know, this will have detrimental effects on blood supply and healing times. I think in the population of dogs that we are discussing here, we're not aiming for an X-ray perfect, absolutely stable anatomic reconstruction of a bone that will take many months to heal fully, but rather methods that will encourage callus formation, rapid healing, and the ability of the bone to bear weight on implant removal before returning to the streets. Also, external fixator or ESF and IM pin combinations, alongside the use of cerclage wire and arthrodesis wires, are significantly less expensive to use. We'll not dwell too long on the complex cellular mechanisms of bone healing, but just give a brief overview. This talk is supposed to be about orthopedics after all. Callus healing that is seen with secondary indirect bone healing can be broken down into 3 main stages: the inflammatory phase, the repair or proliferation phase, and the remodeling phase. The inflammatory phase. The inflammatory phase follows the same sequence of cell events as with other tissues. Firstly, a hematoma forms, followed by an acute inflammatory response with vascularization and the local migration of inflammatory cells, neutrophils, followed by macrophage, and later fibroblasts. This starts immediately upon injury and lasts for approximately 4 days, and it's associated with significant pain, which will subside as this phase ends. Many inflammatory mediators and growth factors are released, predominantly by platelets, and within hours of the trauma, new blood vessels are developing to bring oxygen to the site. Neutrophils and macrophage invade in that order during the inflammatory phase. There is an overlap between the end of the inflammatory phase and the beginning of the repair phase, when the hematoma is transformed into granulation tissue, then connective fibrous tissue by the fibroblast population. Pluripotential stem cells in the area are attracted by chemotaxis and differentiate into chondroblasts and osteoblasts, producing cartilage, then woven bone respectively via endochondral ossification. The periosteum thickens and develops both an internal and external callus, which we refer to as the bridging callus. The callus gradually stiffens and becomes mineralized, providing stability that allows the fibrous union within the fracture gap to undergo ossification. The new bone is not uniform in structure, and although functional, it doesn't have the strength of normal bone. Both endochondral and intramembranous ossification occur within callus healing of a fracture. Intramembranous ossification progresses throughout the periosteal callus, which stiffens and allows endochondral ossification to occur as the interfragmentary strain is gradually reduced to around 2%. The remodeling phase. This involves removal of excessive callus once union has been achieved and osteonal remodeling of the cortices. This is the same case that we saw earlier to illustrate secondary or indirect bone healing with the formation of a callus, but this time we have an X-ray taken 4 years later showing complete remodeling of the bone at the fracture site. The X-ray 4 years later was taken for other reasons, but it gave us a chance to see what the bone looked like. Bone healing times with secondary or indirect bone healing. With dogs under 3 months of age, we would expect the bone to heal within about 3 weeks. Dogs of 3 to 6 months of age, it's going to take a little longer at 4 to 6 weeks. Dogs of 6 to 12 months of age, we're looking at a 6 to 8 week healing time for the bone, and dogs over a year of age, we're looking at it taking 2 to 3 months for that bone to heal. These are the timescales we will be looking at when using intermedullary pins, external fixation, arthrodesis wires and cerclage wire, and that's the type of fixation we'll be discussing later. Primary or direct bone healing will take approximately twice as long for each stage, although the patient would have a more robust and secure fixation which would allow early ambulation and exercise. Here we are talking about dynamic compression plates and the use of lag screws with neutralization plates. This is not something that we'll be discussing today. What happens if mechanical strain never drops below 10%? The result will be a permanently unstable fracture and the development of a hypertrophic non-union. An example may be an IM pin used on its own for a long bone fracture where it alone is not enough to stabilize the fracture. This will require revision surgery to increase stability by using additional implants to allow the callus to bridge the fracture site, or limb amputation. If there is too little strain, say 0%, where there is a large gap, for example a very rigid fixation with a plate and screws and a 3mm gap, then little or no callus will appear and we may get an atrophic non-union. Here we need to destabilize the fixation to allow callus to form through secondary or indirect bone healing, or eliminate the fracture gap to allow a minimal strain environment to allow primary direct bone healing to occur. On the left here we have a hypertrophic non-union of a femur. The original implant was removed, the cerclage wires placed at the time of surgery were left, but the fracture had not healed due to there being too much movement or interfragmentary strain at the fracture site. You can see by the amount of callus formation that this is biologically active. It's just the environment at the fracture site isn't conducive to bony healing. On the right here, we've got a series of x-rays of a radial fracture repair, left to right. Here, the original fracture repair with plate and screws, these implants were removed and replaced with an external fixation device since the fracture gap was not healing. There was no strain because it was a rigid implant, but there was too much of a gap for primary bone healing to occur. Unfortunately, the external fixation device was also of a very rigid conformation and also protected the fracture site against any micromotion, meaning callus healing just would not happen. This shot with the external fixator was taken many weeks after it was applied, so we would expect to see some bony healing here by this stage. Removing a lot of the rigidity of this frame by taking out a lot of the pins and connection bar allowed movement at the fracture site and callus to form, and this eventually went on to heal by secondary or indirect bony healing with callus formation. So with respect to long bone healing, primary or direct bone healing needs rigid fixation and absolute anatomic reconstruction resulting in zero or very low strain and either no or a tiny fracture gap. Secondary indirect bone healing needs micromotion at the fracture site with some strain due to a small gap. Implants here do not provide complete rigidity. This illustrates the point in the last slide. For primary or direct bony healing to occur, we aim for rigid fixation, such as with a plate and screws, and absolute anatomic reconstruction, resulting in a zero or very low strain situation and either no gap or a tiny gap. For secondary indirect bony healing to occur, we aim for micromotion at the fracture site with some strain due to a small gap and use of certain implants, and we get callus formation. I should say that an intramedullary pin alone would rarely be used. We would normally combine this method of repair with either cerclage wiring or a simple external skeletal fixator. In summary, the biology at the fracture site is influenced by the mechanics of the fracture environment. When you have absolute stability, you'll get direct healing and the bone grows across the fracture site with no callus formation. With relative stability, you will get indirect healing and callus forms and turns to bone in a series of biological steps. If the fracture gap is considerably narrowed, it will concentrate the interfragmentary movement and create a high strain environment. A comminuted fracture spreads interfragmentary motion out over several sites, and it so reduces the strain at each site. A nice way of summarizing this is to say that a simple fracture line is mechanically complex, whereas comminuted fractures are mechanically simple. This is because with a simple fracture line, all the forces and strain are concentrated around one small fracture gap rather than spread out. Therefore, it is important to select the correct fixation technique in order to prevent implant failure. We are going to be dealing predominantly with indirect or secondary healing, so we're not trying to achieve absolute stability with perfect fracture reduction. We're using implants and techniques to provide the mechanical environment to allow secondary or indirect bone healing to occur. To this end, we still aim to reduce the fracture gap as much as possible, but we're not so concerned about achieving the perfect anatomical reconstruction or absolute rigidity. There are still some basic rules to follow though to ensure that we do get secondary healing. For example, if the fracture gap is more than 1.5 times the diameter of the bone, then the fracture is unlikely to heal, whatever we do. And similarly, although not aiming for perfect reduction, we do want at least 50% overlap of cortices on 2 orthogonal x-rays, and we'll talk more about this later. Fracture classification. Why classify fractures at all? There's perhaps less need now with the advent of email and CT scanning, etc., since we can simply send an image to a colleague if we want to receive advice or feedback. It used to be that fracture classification was essential to discuss and plan repair with other professionals. Classification is still very important since there are things that cannot be conveyed in a diagnostic image sent by email, such as whether or not it's an open fracture, how stable the fracture is, what age is the animal, etc. There are several different fracture classification systems out there and a confusing array of terms from both human and vet systems. It helps to keep things simple, and this is the system we tend to use in the UK. Fracture classification helps us all, as with an accurate description of the fracture, we can start to figure out how we will repair it. First of all, we would describe the bone that's involved. Which bone is it? Femur, humerus, tibia, radius, etc. The next stage would be to describe whether it is an open or a closed fracture. Open fractures have full thickness skin wounds and can be subdivided into grades 1, 2 or 3. Grade 1 open fractures are where the bone penetrates the skin from the inside and then retracts back in, and the wound is less than a centimetre. This is often a clean wound. In grade 2, the skin is penetrated from outside and the wound is over a centimetre. Often foreign material is present, so this is usually a contaminated wound. And finally, grade 3 shows significant soft tissue loss and injury to varying degrees, often road traffic accidents or gunshot wounds. We can then go on to describe which part of the bone is involved. For example, the epiphysis, the physis, the metaphysis or the diaphysis. If it's the diaphysis, then describe whether it's the proximal, middle or distal third, and if it's the epiphysis, describe whether or not the fracture is intra-articular. Diaphyseal characteristics. For example, simple fractures will have 2 pieces of bone and 1 fracture line, whereas comminuted fractures will have more than two pieces of bone with more than 1 fracture line. Simple fractures can be transverse, oblique or spiral, and comminuted can be mild, moderate, severe or segmental. Avulsion fractures can also occur where the bone is actually pulled away from the diaphysis, and we'll talk about more about these in a minute. The extent of the fracture, describe whether it is complete or incomplete. Complete fractures involve the full circumference of the bone involved. Incomplete fractures, only part of the circumference is involved. For example, greenstick fractures in young animals and fissure fractures in adults. Fissure fractures are also called hairline fractures, often present extending out from the main fracture site, but they can exist alone. Growth plate or physial fractures have their own classification system called the Salter classification, and I will go into this in more detail in a minute. An articular fracture is one which involves the joint, either one of the Salter classification of growth plate fractures or a comminuted fracture that involves the joint. Subchondral bone is disrupted in an articular fracture with or without hyaline cartilage involvement. Articular fractures need to be identified because they need accurate anatomical reconstruction to minimize the formation of callus and to reduce the severity of degenerative joint disease later. Stability. Stable fractures can maintain some stability after reduction without implants. Unstable fractures cannot maintain stability after reduction. So a fracture can be described as either stable or unstable. The cause of the fracture. It's usually traumatic forces acting on normal bone, such as a fall from a height, gunshot, road traffic accident. Low energy fractures would include a fall. High energy fractures would include those caused by road traffic accidents and gunshot wounds. You can also have normal forces acting on abnormally weak bone, for example, bone affected by osteosarcoma and nutritional or renal secondary hyperparathyroidism. And this latter cause of pathological fractures is something you might come across in street dog populations where young dogs may be fed a predominantly meat diet, and these dogs may have nutritional secondary hyperparathyroidism. Other descriptive terms for fractures. Fracture could also be described as being overridden or displaced, and the degrees of each could be included in the description. There's various classification systems in existence for particular bones, but because we're not addressing these types of fractures today, I'm not going to bother you with them. I'm going to talk a little bit more about diaphyseal fracture classification because these are common fractures. Diaphyseal fractures can be classified as simple, comminuted, or avulsed. Simple fractures consist of 2 pieces of bone and 1 fracture line. Comminuted fractures consist of more than 2 pieces of bone with more than 1 fracture line. And avulsion fractures exist where the bone has been pulled away from the diaphysis. Now, simple fractures can be described as transverse, and this is where the fracture line is less than 30 degrees perpendicular to the long axis of the bone, and they can be described as smooth or interdigitated, with the latter providing more stability. They can also be described as oblique, where the fracture line is over 30 degrees perpendicular to the long axis of the bone, and they can be described as either short oblique or long oblique. They can be spiral, and in a spiral fracture, the fracture curves around the bone and is not straight in any one plane. And these types of fractures are more typical in tibial and humeral fractures due to the shapes of these bones. Comminuted fractures can be mild, moderate or severe, and a segmental fracture is where the two fracture lines are separate, leaving several complete bone segments between them. Avulsion fractures are more common in young dogs, where the physis separates and the bone is pulled away, and these occur at the point of insertion of tendons and ligaments. The physis represents the weak point, and so it gives first. Here is a diagram of these diaphyseal fractures that we've just described. I'll show lots of examples of x-rays of these later when we discuss repairing them, but I just want to concentrate on the basics just now, just to keep things concise. So starting at the left, we've got simple transverse fracture here, simple oblique, short, simple oblique, long, a simple spiral fracture that spirals down around the back of the bone and back here, comminuted segmental fracture with two separate fracture lines and a segment of bone in the middle, and a comminuted fracture where you can have multiple fracture lines with multiple fragments or segments. This is an example of an avulsion fracture, in this case of the tibial tuberosity, which is avulsed or been pulled away from the proximal tibia. Tibial tuberosity develops by a separate centre of ossification, and it's separated along the physis or growth plate. Tibial tuberosity is pulled by the action of the quadriceps muscle on the patellar tendon. This set of diagrams illustrates the Salter classification of growth plate or physial fractures. Starting from the left, we have a type 1, which is just a simple fracture across the physis or growth plate. Salter type 2 fractures are fractures that occur across the growth plate with a small portion of the metaphysis included. Salter type 3 fractures they're articular fractures. They fracture through the epiphysis and across the physis. Salter type 4 fractures are also articular, and they fracture through the epiphysis, through the physis and into the metaphysis. Salter type 5 fractures are compression or crush injuries of the physis, and these can be quite difficult to see on x-rays, and we'll show an example later. There is also a Salter type 6 fracture, which I haven't illustrated here, which has compression or crush injury of part of the physis, not the whole physis. Let's look at some examples of these fracture types. I'll say just now that I've only included one view of each fracture, but for a more accurate description, and certainly to plan a repair, you'll need two orthogonal views. In this image of an x-ray, we've got a simple, complete transverse fracture of the distal radial diaphysis here. There is a large degree of overriding of the fracture ends with distal displacement of the proximal segment. There is an accompanying simple, complete transverse ulnar fracture at the same level. What you can't tell from this x-ray is that this radial fracture was also closed, and it was very unstable. When describing radial and tibial fractures for that matter, it's important to also describe the situation of the ulna and fibula respectively. These often fracture with the main bone, but if not, then they will act as stabilizers for fixation of the radius and tibia, and it might affect how we choose to repair the fracture. We could possibly aim for a less rigid fixation of the main bone if the ulna and the fibula are intact. The ulna and fibula are not normally repaired themselves since they're not weight-bearing bones. However, in large breed dogs, repairing these smaller bones will assist in providing additional stability to the main fracture repair of the radius or tibia. This is a short oblique fracture of the distal radius with an accompanying ulnar segmental fracture. This fracture was open, it was overriding, and it was unstable. So that's how we would describe it in addition to the x-ray description. The radial fracture you can see quite clearly here and here, and this is the ulna, the proximal ulna coming down here, distal ulna is here, and we've got a fracture line there and a fracture line here, so this is a segmental fracture of the ulna. This is a long oblique fracture of the midshaft humerus of a juvenile cat, and you can see quite clearly that's the length of the fracture line here, and on the proximal segment it's here. So that's a long oblique fracture. This is a spiral mid-shaft tibial fracture in a young cat. It might be quite difficult to see on X-ray, but there's a faint line running down here, and then it comes around and the fracture line travels on down here, so it spirals around the bone. Similarly, on the lateral, medial-lateral view, you can see the obvious fracture line coming down here, but it does travel around the other side of the bone here. This is a minimally displaced fracture. On this slide, we have two X-rays exhibiting severely comminuted fractures. On the left here, we've got a severely comminuted fracture of the distal humerus, which was very unstable. And on the right, we've got a comminuted mid-shaft fracture of the femur. Again, this was completely unstable, which you can appreciate from the X-ray. This is the radial fracture from a few slides ago, which I've included again because it's the only image I've got of a segmental fracture, this time the ulna. And you can remember before, this is a segment of the ulna in the middle with a fracture line here and a fracture line distal, so it's a segmental fracture. Segmental fractures in major long bones would definitely need repaired, whereas this ulnar fracture would be left to heal itself once the radius had been stabilised. This is a very common fracture. It's an avulsion fracture of the tibial tuberosity in a young dog. Tibial tuberosity here has been pulled away from the tibial diaphysis by the action of the quadriceps muscle, patellar tendon. This is a distal femoral physial fracture, which you can see here, illustrating that the distal segment is getting pulled caudally and proximally by the associated attached soft tissues and muscle. These are usually Salter type 1 or 2 fractures and classically occur in young animals, where this is a growth plate, and you can see quite clearly the tibial tuberosity growth plate here. This is a distal tibial growth plate in a young dog with the normal leg here on the right hand side and the injured leg on the left hand side. This is a Salter type 5 growth plate or physial fracture, and they're very difficult to pick up on X-ray since there is no displacement of the bone, but instead just compression of the growth plate. These fractures often go missed and only become evident many weeks later when the dog develops a growth deformity of the affected bone. I've highlighted the tibiotarsal joint space with yellow arrows here and here, and the distal tibial growth plate with red arrows here and here. And you can see that the growth plate on the right appears to be open. You can see that dark line running along there. That's the open growth plate. Whereas on the left, that dark line has disappeared. That bone has been compressed. So important in this case is that we keep a very close watch on the growth of this bone over the next month or so. I should just say briefly regarding that previous slide with the Salter type 5 growth plate fracture, although the X-ray looks normal at first glance, these dogs are acutely lame. They behave as if they've got a fractured leg. Here we have an incomplete fracture. As it says, incomplete fractures do not involve the whole circumference of the bone. For example, green stick fractures in young animals, it often looks as if the bone has just bent. This was an unusual presentation in that it was an incomplete fracture of the distal tibia in an adult greyhound. This is an intra-articular fracture of the lateral humeral condyle in an adult dog. You can see the dark fissure line between the humeral condyles, the medial and the lateral condyles. This is a fracture line going through here into the articular surface. And here we've got the obvious fracture of the lateral condyle. So this whole lateral condyle is completely separate from the humeral shaft. And although these look simple, they can be difficult to repair and they require perfect anatomical reconstruction of the articular surface of the humeral condyles. This needs to be perfectly reconstructed. They're normally repaired with a combination of screws and plates. This is a pathological fracture. This distal tibial incomplete fracture is very obviously in an area of unusual looking bone. This is an osteosarcoma, which has weakened the bone and predisposes to fracture under normal weight-bearing forces. The bone tumour may not always be this obvious. Again, if in any doubt at all, X-ray the contralateral bone for comparison.